Hey Constance, how are you doing?
Good, Sarah. How are you?
I'm good. It was so nice to get to see you in person last week.
Yeah, it was great visiting New York. Got out to all the way to Mantuan and had a beer at the Mantuan Brewery.
Oh, nice, nice. Well, we have someone joining us today. I'm really excited about. His name is Brian Blase. He was a key influencer, or is a key influencer on American health and policy reform. He's currently the president and CEO of Blase Policy Strategies. And previously, he worked with the Trump administration to kind of spearhead the HRA rule. So let's get to it.
Great, excited to hear a challenge working in Republican led state and being able to bring both sides together and put a bipartisan bill to
Yeah,
put ICHRAs in place. So this should be interesting.
great. Let's get to it.
Cool.
So, welcome, Brian. We're so glad you were able to join us today. I know everyone's been quite busy over the past several months and going into fall, so we appreciate you giving us some time. Why don't you introduce yourself for our listeners?
Sure. Thanks, Sarah. It's great to be with you. My name is Brian Blase. I have sort of made a career out of doing health policy. And so most notably, I served at the National Economic Council in the White House for the first 2.5 years of the Trump administration. Prior to that, I've worked on committees in both the House of Representatives and the Senate. I've done lots of work for sort of market-oriented health policy think tanks. When I left the White House in the summer of 2019, I sort of set up my own policy and research company, Blase Policy Strategies.
Great. So, Brian, what got you into healthcare to begin with?
I've always been really interested in public policy. And when I was a graduate student studying economics at George Mason, I took some really interesting classes in health economics. And I was sort of appalled by how bad certain healthcare policies are and sort of all the perverse incentives in the system and how sort of the U.S. spends so much money on stuff that doesn't really make us any healthier. And I got a position in early 2010 as a graduate research fellow at the Heritage Foundation. And the Affordable Care Act passed when I was there. And my career has sort of gone parallel with the Affordable Care Act. I've had lots of different policy jobs studying both the Affordable Care Act as well as a lot of the other government healthcare programs.
Wow. Yeah. So you kind of went right into it, and actually, you hit the topic right on the head with this introduction of yourself and how you got into healthcare. We invited you to come talk to us a little bit about the HRA rule. You helped spearhead that, and so why don't you tell us a little bit about what you were doing, what your role was, and how that's grown over the past couple of years?
Sure. So the National Economic Council coordinates economic policy for the administration and really represents the president. So you work with a lot of federal departments. There are several federal departments that have equities in healthcare. Everyone who listens will certainly think of Health and Human Services, but also the Labor Department, since 160 million people get their insurance through their employer. And then the Department of Treasury and the IRS. There's a lot of healthcare provisions in the tax code. So I'd work with all those departments as well as the other divisions sort of within the White House, like the Office of Management and Budget, the Council of Economic Advisors, the Domestic Policy Council. And I really was in charge of spearheading what I called sort of the tri-department healthcare process, which was coordinating the activities across those federal departments to try to implement health policies consistent with the president's agenda.
Wow. So why did the Trump administration issue the HRA rule?
In the summer, so 2017, if you recall, the sort of key political debate was around the Affordable Care Act, and Republicans
Right.
had made lots of promises to sort of deal with problems with the Affordable Care Act. A lot of sort of the first 2/3 of that year was spent with Congress trying to figure out what they were going to repeal, what they were going to modify. And it turns out they weren't able to do anything, which really let us in the administration on the hook to try to figure out, okay, what can we do to help people with more affordable options, particularly people in the middle class that didn't have offers of employer-sponsored insurance, as well as small businesses. I mean, there was a significant decline in small businesses offering insurance. And I called in the departments and was like, okay, we're going to do whatever we can to increase affordable coverage options, promote competitions in healthcare. What are your ideas? And we sort of put some ideas together, and several of them went to the top of the list, and they became part of an executive order. So President Trump in mid-October of 2017 signed an executive order on enhancing healthcare choice and competition across the United States. And it had 4 actions in there. And one of those policies was to consider rulemaking to open up health reimbursement arrangements, HRAs, so that they could reimburse premiums for individual market coverage. And that has sort of been sort of a long goal of a lot of the sort of free market health policy movement, is to try to get as much control in the hands of the individual consumer, the individual worker, as possible. If you think about employer-sponsored insurance, I mean, it's wonderful for several reasons, but it also has some drawbacks. And one of the drawbacks is your employer picks your health insurance. And at 75% of employers, and particularly small employers, workers only get one option. So, I mean, think about what other major financial product that people buy, do they only have one option? And we're like, let's create a way for employers to compensate workers with health insurance, where it's sort of the 401k analogy, where they can provide the contribution, and then the workers can go and pick the plan that works best for them in the individual market.
I have a quick question for you, Brian. So in the 2000 ACA era, many employers, large employers in particular, were coming out with defined contribution models. So giving their employees something like $3,000 to $5,000, you can spend it how you choose to on a health plan and potentially other ancillary products that they might offer. How does this differ? Like, I understand that the ICHRAs can have more plan design choices, but I'm thinking a large employer could have done that too. They typically limited it to 3 or 4 just to keep things in order. But is defined contribution, even though it's not technically in an HRA account, how are those different? And especially for a large employer who's looking at the pros and cons of ICHRA versus defined contribution.
So on sort of allowing employers to reimburse individual market premiums, it was sort of a nebulous legal area prior to the Obama administration issuing regulations that eliminated that possibility. So they put a $100 fine per worker per day on employers that would reimburse premiums for individual market coverage. It is a good question. So what the Trump administration did was make it legal. So the HRA rule is 500 pages long, and I know we'll talk about some of this in more detail, but it's a lot of sort of how to balance employer flexibility with guardrails to protect the individual market. But it is just for individual market coverage. I mean, employers.
Interesting. So it allows the individual market to be more competitive, if you will.
Well, that's one of the hopes. You know, the individual market is much smaller than was expected when the ACA became law. It's like less than half the size. And in large part, it has become sort of a market for heavily subsidized individuals. And one of our concerns is that the plans offered in the individual market aren't attractive enough in order for employers to move employees there. Now, I think that is changing. And in some areas of the country, the individual market is much stronger. but I think it still remains a challenge to overcome. I mean, to your broader question of why don't employers like set up a private exchange, contract with a couple of insurance companies, set up a private exchange, give their workers a set amount of money and have them purchase health insurance? That's a good question. I don't know why that model has not really taken off.
So do you know all 500 pages by heart, Brian?
No,
So I was wondering from the time you first started approaching the different departments and started drafting this to the end rule that has been published, are there some like key differences or things that were added as the process went along?
So the process started like I mentioned, we had meetings in the summer of 2017 on sort of what ideas could we work on in the future.
Right.
And then we wanted the president, after the congressional failure, wanted to show he was doing something. So one of the ways that presidents show that they're doing something, and this is, across all political parties, is they sign executive orders. And executive orders by themselves, often people get confused that they just change policy. They don't, right? They are direction to the departments to take future actions. And here you had to go through the rulemaking process. So that involves doing a proposed rule. One, it involves the departments have to have this as their top priority because they've got lots of other things that we're working on. And I mentioned there were other parts of the executive order. This was going to be the most complicated rule change by far. And it's the one that we worked on last. So we really started sort of the heavy work around the proposed rule in the spring and summer, early fall of 2018. The rule was proposed. And again, it's many hundreds of pages long, and it asks for lots of input from the public. For example, one of the areas that ICHRAs allow flexibility is that it allows employers to divide workers into separate classes. So say that they just want to offer coverage to part-time workers, offer individual coverage HRA, the accredited as part-time workers. They can keep they can keep the other workers on a traditional plan and then offer it to part-time workers. So we wanted feedback on classes. So once you get the proposed rule, you get the comments that come in. And then of course, the comments came in and they went into the IRS. And if you remember, late 2018, early 2019, the federal government shut down for 5 weeks. Yeah. So we had comments coming in, but the government was shut down. So it took a little bit of a delay in the process to evaluate the comments. But we started evaluating the comments, and one of the areas we asked about was whether we should add a class for salaried versus hourly workers. And we ended up doing that. We added a class for salaried versus hourly workers, so that if employers want to keep salary workers on the traditional plan and move hourly workers into the individual coverage, into the individual market with an ICHRA, they could.
That really, point, Brian, is so critical. Today's economy, we've seen that so many workers are being brought on as, let's say, temp to hire, right? Project management to hire. They'll get a part-time role, a non-salaried role, a per hour role, even if it's 40 hours a week, but they really don't qualify for those benefits. But being able to offer something to those workers as part-timers, quote unquote, is probably a very, very growing opportunity in the market.
Yeah, Constance, and that's a good point. And so too, with the changing work environment of people working from home, you've got companies that have workers all over the country. Well, think about that challenge for an employer in trying to select a plan for workers that are geographically dispersed all over the country. What a much more flexible and convenient option for them to provide this contribution. And then the workers in Florida can pick plans that are best for them, the ones in Texas, the ones in New York. There's so much flexibility that the rule offers.
So what kind of adoption rate have you seen now that we've kind of rolled out ICHRAs?
That's a good question, and we really don't know the answer yet. It was projected. So the Treasury Department did micro simulation modeling for us. And they projected, and so this is basically they're constructing firms, and they're modeling for those firms and the firms' workers, where's it going to make sense for them to offer the HRA versus the traditional group plan? And they projected that, by the middle of this decade, we'd have about 11 million people enrolled in the individual market with an ICHRA. About 1 million
today?
of those.
What's the number? What again was the number for today?
11 million. So they said we'd have about
based
11
on
million.
How many are enrolled today?
Well, that we don't know. So it would be great to know how many are enrolled now. We don't have a good way to collect that data. Insurers don't report the number of people that enroll using an ICHRA. We have launched a coalition to support HRAs, and one of the aims of that coalition is to gather data. And really, it's a really important mission because policymakers want to know how it's going and not only the number of enrollees, but also what's the characteristics of the firms that are moving their workers into the individual market. So we've got some anecdotes, but not really any firm data.
Well, we'll have to invite you back year after year to see where that climbs.
Right, come back and report on the numbers. So I guess the last question I have is, I find this fascinating because I am not particularly political myself, but healthcare is a very hot topic when it comes to politics, and people have very strong feelings. This seems to have been a fairly bipartisan rule, and I see people on both sides of the aisle who are staunch advocates for it and pushing for it. Why do you think that we have this bipartisan agreement on the HRA rule and ICHRAs?
Yeah, Sarah, good question. I often joke that it's one of the few major things I worked on in the Trump administration that we didn't have immediate lawsuits filed on it from Democratic attorney generals. And I think it is because it's about expanding coverage, and it has something that is deeply satisfying to both Republicans and Democrats. So Republicans, like I've mentioned, have wanted to move to defined contribution health insurance for decades. They have criticized the tax advantage that goes to employer-sponsored insurance and have thought about how to equalize that. And really what the HRA rule is, at its core, it's an equalization of the tax benefit between traditional group insurance and this contribution that the individual uses to select the plan in the individual market, right? These contributions in both cases are not subject to federal income or payroll taxes. For Democrats, this is an expansion of the ACA. So everybody who uses an ICHRA is going to use it to purchase an ACA compliant plan in the individual market. And that should improve the individual market over time. My sense is, and my expectation is, that it's going to be firms that have younger workforces that are healthier and don't have an established provider network where people might be very concerned about change to that traditional plan. So if we get firms that are younger, healthier, moving into the individual market, adopting this model, that improves the overall market. That's going to lead insurers to re-enter the market, offer more products that will increase competition, lower prices, which will make the individual market more attractive for employers to offer ICHRAs to their employees. So really, I mean, my hope is, and this is gonna take time, right? I call it sort of this virtuous cycle. And the analogy really is 401ks. So 401ks revolutionized the way that people save for retirement. And they started January 1, 1980. ICHRAs are 40 years to the day after 401ks started. And, I think adoption is going to take time. And I'd still like to see more support from Democrats. I think they haven't been as interested in it as I think. I hope once we sort of get through the political season that we're in right now, and we get to some bipartisanship in healthcare policy, that this really is a chassis that we can build sort of lasting bipartisan health reform on.
Well, it's kind
Yep.
of cool because if you go back to your 401k analogy, there are so many people now that 40 years later have a nest egg of investment, right? And return on that investment and the tax advantage with that. So, doing the same for healthcare, you might allude that at some point we will have more people enrolled in insurance, more people getting preventative care, more people involved in their care because they have choice and they have dollars. And that's the trend that we're really trying to address in healthcare, which is unsustainable costs and sicker Americans.
Yeah, well, Brian, thank you so much. WELL is part of the coalition with you, and we're very excited to see where this grows. We are talking to people all the time about it, and I agree with you. I agree with Constance. That seems to be the best analogy, is the 401k. It's not going to happen tomorrow, but gradually we'll see more people do it. And I was speaking to someone just the other day who even said, similar to Medicare, how when more people get in it, you see more robust plans. So it's a little bit of chicken and egg, a little bit of this virtuous cycle, like you mentioned, and we're going to have to all play our part to see. But I really appreciate you giving us some time today, and we should make this at a minimum an annual recurrence so we can go over the numbers with you.
I'd be happy to do that. Thanks for
Great.
the time.
Thank you
Thanks,
guys so
Brian.
much. Bye-bye.
Be
Bye.
well.